And there are some signs that help you to put it across 1 and 2. So we will deal with some of this. But don't forget, there are connective tissue, muscle, fat, nerves, vessel, lymphatics there. And then you could have lesions coming from outside the pelvis to the pelvis in the form of metastasis. Then you have the bone, then you have the meninges in the spinal canal, so many more things. They all can present as pelvic masses. So that is something in your head. That always remember there's a lot of things. And then we will try to be sure where this lesion is coming. Okay? Then another thing, so this is location wise, but when we see a lesion, the first thing that we want to do as a radiologist, is it a cystic lesion? Sorry, is it a solid lesion? Then does this lesion have blood? Does it have fat? Does it have myxomatous tissue? Does it have fibrous tissue? Like that. That's called lesion characterization. On top of that, we add the shape of the lesion, the margins of the lesion, okay, maybe diffusion restriction, maybe color flow. So all those things, around all that, that becomes the lesion characteristics. Then think about various differentials that would fit the characteristics and the location. So that's a general approach that I want to put forth to you. Hopefully, we can do the rest of the cases based on these. All right. So here we go. I think here. This is some of the things I mentioned. Easy to characterize and see whether it's a cyst or a solid. In a cyst, we can go further saying, is it uniloculated, biloculated, multiloculated? Does it have solid component? Generally, if the solid component is more than 80%, we call it a predominantly solid lesion. This is in terms of ovarian or adnexal masses, all right? And then we have restricted diffusion. If you take one characteristic like a restricted diffusion in MRI, even abscesses and epidermoids and dermoids do restrict, all right? When you say fat containing, it's not just a dermoid teratoma. You can also have lipomas, you can have liposarcomas, you can have myelolipoma. So if you see that, there always one particular characteristic can actually mean so many more differentials. If you go down the line, there are some things like paragangliomas, which can also arise there, and they can be hypovascular. You have solitary fibrous tumors, and you can also have vascular lesions in the pelvis. So this is in a nutshell, where all you can have lesions, but really not talking much about any lesion. All right. So this is our first question of the day. So this is a 45-year-old lady who had previous ovarian cystectomy. It was a benign lesion. This is an ultrasound of the abdomen, transabdominal ultrasound. This is done of the pelvis. Just to give, I've used static images to make our discussions, more targeted rather than generally we have a whole series. I can just orient you. So that is a Foley's catheter in a collapsed bladder. So would somebody like to take this case? Maria, can you coordinate that?
Yeah, Elroy is taking it first.
Yeah, so
okay, Elroy.
Yeah, this is an ultrasound static image of a 45-year-old lady with previous ovarian cystectomy. I see that there is a fluid collection which is not conforming to any cystic area. It is having an irregular shape, and also there is a septum connecting within, which is and with the ovary eccentrically located. So this could be the spiderweb appearance as in peritoneal inclusion cyst, considering the history of surgery.
Fantastic. So there you go. I think you're all set for the exam. I was trying to get my pointer out and to show you all these things. There you go. You said you're not even asked for the next imaging. So all right. So that is what it is. There you can see the ovary. You can see sort of a adhesion or a band. You can make out that it is sort of conforming to the pelvis rather than being a spherical or an oval lesion. So there you go. This was the appearance of on MRI. Can we just, for the sake of going through it, can you go through it, Nick, with me? Yeah. Hello.
Hi. Is this my case?
Yeah.
Okay. So we've got a MRI through the pelvis.
That's a T1.
Yeah, sorry, I think someone muted me. Okay, so we've got an MRI through the pelvis. We've got T1, T2, a fat sat in the center.
Okay.
Another fluid sensitive, what looks like another T2, it's a fourth from the left, and then possibly a restriction diffusion image on the end.
Yes.
So there's a multilocular region of fluid adjacent to the uterus.
All right. It's in the left adnexa. So it's
Yeah.
in the left adnexa. That is the ovary, which is sort of
Yeah.
in the center. So that is a very classical spider in the web appearance. Okay.
Yeah.
So sorry, I passed it on to Nick. Elroy, do we need to do anything about this? That's my question. Do we need to do anything about this finding?
This is a leave alone condition unless the patient is symptomatic.
What if it is very large? What if the size of this lesion is more than 10 centimeters?
Yes, then if it's more than if it's a large size, there's a risk of torch.
Unless it's clinically symptomatic, even if it is large, it is generally a leave it alone lesion. So that is why the special appearance helps. This 10 centimeter, if you go to ORADS, which we will touch upon later, which deals with, making very definite criteria for giving a score on all adnexal and ovarian lesions. Generally, the 10 centimeters taken as cutoff for a lot of lesions, but peritoneal inclusion cyst of such typical appearance, I think we can basically leave the lesion alone. So, all right. So that was our first case. This, I didn't even think of making it a quiz question because it's very obvious. So it's a very classical appearance. So this is tubular. You can see that it is C or S shaped, or like that of a retort shape. You can see that the septae are incomplete. This was an hydrosalpinx. And in the MRI, this is a T1 weighted image, but you can see that this tubular structure is T1 hyper intense. So this turned out to be a hematosalpinx. So this is just for you to remember hydrosalpinx and hematosalpinx, which are part of our common benign leave alone adnexal lesions. Okay. So this is the next case. Do we have can anybody take this case?
Yes, sir. Yes, ma'am. Hello.
Sadav?
Yes.
Oh, hi there. Nice to have you.
Hello.
Can you take, I'll just give you orientation. Yeah, I haven't put an image here. So this is a transabdominal ultrasound done at the level of pelvis. So you describe what you see and then let's go ahead to the next set of images.
This is one of the spot views of an transabdominal ultrasound pelvis, which shows a large, highly echogenic lesion, which is found within the pelvic region. Considering that it's well defined, there are no internal calcifications within it. I cannot appreciate any cystic areas within this lesion. I would like to see its relation with the ovary, as well as its relation with the fallopian tubes, to determine the exact extent of this lesion, as well as the nature of this lesion. And considering this high echogenicity, my primary differential can be that this is a hemorrhagic large cyst, and other differentials, since it does not have any fluid levels within it, and I cannot appreciate any calcific nodule. So other differential would include teratoma.
All right. So I think that was also sort of what actually our preliminary ultrasound was also like that. It's a bit lobulated. So I'll sort of now fine tune. We had two classical cases. Now I'll fine tune it to the lesion. You saw that it's echogenic. So echogenic, one of the differential would be a fat containing lesions. I agree with you. Some of the fluid can also have a solid looking or echogenic appearance. We have to keep that in mind. We can look for through transmission to help us out with those solid-like, or it appears like solid. That is something we have to keep in mind. Then the other thing that we look for is the lobulation. Okay, so the margins of the lesion. So that is also something, whether it is very smooth or whether it's lobulated, that's another feature that can help us, okay, to characterize the lesion. It's another finding here, which we actually had missed initially. We will come to it as part of our science as we deal in later. So Sadaf, next set of images for you.
All right, so these are the MRI pelvis images of the same patient, the T1 weighted image, as well as the T2 sagittal and T1 post-contrast images are available. I can appreciate that this lesion
This is
is
T1. Sorry, Sadaf, let me just interrupt you. This is
yes.
T1, that's one fat
Yes.
sac. These two are T. Sorry for not naming them. Yeah, that's a T1
Okay.
fat sac.
Oh, this is T1 fat sac. All right. Okay. So I can appreciate that this lesion is hyper intense on T1 weighted images, which shows a few internal hypointense septi. However, its anterolateral margin is slightly indistinct with the uterine body. Madam, the left lateral, yes, the anterolateral margin. However, rest of these margins are well defined, lobulated. There is no hypointense calcification within this lesion. On the T1 fat sat images, I can appreciate that there is a loss of signal. That means that it is predominantly fat-containing lesion. On the sagittal images, I can appreciate that it is located in the fundus of the uterus with significant enlargement of the uterine cavity with obliteration of the endometrial canal, as well as mass effect on the adjacent uterine musculature. Subtle mass effect is also noted on the superior surface of the urinary bladder. However, the fat planes are maintained, suggesting that there is no definite invasion of this lesion into the urinary bladder as yet. However, the anterior uterine wall is significantly thinned out with only a streak of hypointense serosa intact. However, most of the uterine myometrium is replaced by this lesion. So considering that this has an irregular anteroleft lateral margin, and there is a lot of the and myometrial thinning, and it is a predominantly fat containing lesion. So, and considering the age of the patient, my primary differentials would include a liposarcoma, and other differentials, the age of the patient is not likely for a dermoid or a teratoma, and it can also the signal intensities are not suggestive of leiomyosarcoma. However, and it is very unlikely to have this degree of fatty degeneration in a previously known uterine fibroid. So my primary remains liposarcoma of the uterine cavity.
All right. So I think fair enough. You are comfortable describing. So what do you think that this T2 hypointense line indicates? Do you see that?
Yes, yes, I can appreciate this. Yes, this is the
First capsule, right?